really loving Serbian hospitality and this wonderful country, and I'm pretty sure you will love mine. I'm from Sardinia, and if you are interested in salivary glands, major salivary glands, please join us in October. That's the best period to be in the best seaside in the world. There is an international faculty, and you can send abstract, you can participate just to learn something, to share your experiences. Thank you very much, and let's go to the issue I'm here for, which is nose vestibule malignancies. And to get to say that there is a new standard for the treatment of these malignancies, we need first to define what we mean with nose vestibule malignancies. These are lesions arising from the most anterior part of the nose. Okay? It's not working. For the most anterior part of the nose, which is the area where skin becomes mucosa. Okay? And it's simply a subsite in the nasal cavity. But it's a subsite involving the anterior part of the septum, of the floor, of the lateral wall, and the mucocutaneous junction until the skin outside, columella and superior lip. And it has clear peculiarities because it's rare. But the main issue is that it's misclassified, because it's put together with nasal cavity malignancies or to skin malignancies, but it's something completely different. So I will show you soon that AJCC is inadequate in these cases. And the misclassification, if we follow the AJCC classification for malignant tumor, we'll put nose vestibule malignancies, together with nasal cavity malignancies, okay? And we will say that nose bone involvement doesn't make an upstaging, and that skin involvement makes automatically a T4. But it's, I mean, it means that all nose vestibule malignancies are T4, because if we look at here, that's the typical spread for these tumors. We see that on the lateral wall, they typically go, and it's pretty frequent, you will see some pictures soon of real patients, they always follow our planes when we do the rhinoceptoplasty. So they go between the alar cartilage and the lateral cartilage, and the skin is practically always involved when the lateral wall of the nose vestibule is involved. And the superior lip is very often involved when the inferior wall of the nasal vestibule is involved. And when the septum is involved, they can also go behind. But of course, in this case, you don't have skin invasion. So we will see that in the AJCC classification for nasal cavity diseases, these primaries will always be T4 for skin involvement, while the bone involvement, which in these malignancies is an ominous finding, could still be a T1. The best way to classify these diseases, therefore, is not AJCC. It's the Wong classification. It's an old paper dating back 1976, and that's what we use in our clinical practice. So, big problem with misclassification. Diagnostic workup is not a big issue because inspection and palpation are the best tools we have, so our eyes and our fingers. We are surgeons, we can use them very well. If we need something more from imaging, and of course when staging a malignancy you should follow a standard, we use MRI. It's very easy to see that it seems a small lesion, but it goes exactly on the lateral wall as I just described. So from the internal part, the lateral wall of the nose vestibule, between the alar and the lateral cartilage directly to the skin. This is a columella lesion, again with MRI. Here is the patient. You will see also the result later. And also PET-CT can be useful in selected cases, not just to confirm what we see and what we touch, but to exclude nodal metastasis, because level 1 often you see enlarged nodes and they are not specific. And most of all, to have a baseline when you treat them with a non-surgical treatment, because you can quickly assess the response after the treatment after, for example, the irradiation. Irradiation is an option in these cases, as surgery is, and as brachytherapy is, which is a different irradiation. It's not external beam, is an old technique which was used widely in Europe in the last years, mostly by radiation oncologists, and that's the key point. And you see this is a Dutch group with a large series of about 90 cases. It's not very recent paper, it's 2006, okay, with good result. But we can say more. We can say now, basing upon the data I'm going to show you, that brachytherapy is now the new standard for this nose vestibule lesion. Brachytherapy is the first radiotherapy. It means that you put the source of radiation in close proximity or inside the tumor. It was abandoned because of exposure issue, because you had to manage directly the source in the low dose rate in the ancient times. So it was a big problem for the physicians, for the operators, and for the visitor of the patients. But now we have the possibility with remote afterloading and pulsed dose ratio and high dose ratio modality, which is the one I currently use, to not to be in contact with the source. So the source is inside this machine. It's inside this machine. Can you see it? Okay. The afterloader in a bunker, and you put some tubes in the tumor and around the tumor. The patient goes twice a day in the HDR modality, twice a day for 10 days in this bunker, and the source passes along the tubes, and you decide how much dose is getting by controlling the time the source is staying in the section of the tube. So you can do an intensity modulation, and you can plan your treatment on the images. So it's intensity modulated, image-guided brachytherapy, exactly as the external beam. And with these new technological possibilities, we decided to exploit this tool in the head and neck. I just described our results until 2017. Now we have, of course, more cases on the head and neck. It's just been published. You can find it online, or you can ask me, and I will send you promptly. Just to show you, I'm not going into detail, just to show you which is the biggest group where we use the brachytherapy. It's the group 4. Group 4, and you see in the table, most of the group 4 are nose vestibule. The group 4 is made up of mid-face malignancies, which means the central part of the face where mucosa becomes skin and skin becomes mucosa, exactly as in the nose vestibule. And this part of the face is characterized by two main issues. The minimal imperfection, deformity, scar is immediately noticed. If you do rhinoceptoplasty, you know that. So if you make a resection, it's practically impossible to rebuild the complex of reliefs and of hollows, for example, made up by the nose framework and by the nose cartilage. And so reconstruction is absolutely difficult, I may say impossible, because free flap are too much and the local flap are not enough, and you cannot reconstruct the form of the cartilage. So preservation of the anatomy for the cosmesis of this area of the face is by far the best option. Sorry. And we published our preliminary results on nose vestibule in 2015. And these are a comparison between surgery in these cases and brachytherapy. These are common results of surgery. And I believe, you are rhinologists, I believe you have seen nose vestibule cancers. They are much more frequent than literature reports because they are misclassified. And in this case, they are easy to take out, very easy because they are there. But the problem is to reconstruct them. And the bone-anchored prosthesis remains the best option. While with brachytherapy, these are the results. This is a perfect case. That's a T2, infiltrating the skin, according to Wong, of course, because in AJCC it would have been a T4. Infiltrating the skin, that's a case I showed you before, okay? And we made the implant respecting the planes of the nose. We will discuss about it soon, and that's the result a few months later. So it's impressive, I guess. And the other case, it's even a T3 according to Wong. You shouldn't treat it by brachytherapy, but the patients didn't want his nose to be taken out. And so we did it by brachytherapy. That's the result, complete response. That's the only patient who died in our series for invasion through the pterygoid plexus. But all the other 20 patients, especially the 15 primary tumors, they are still alive. And here is the satisfaction degree of our patients compared with surgery. Of course, it's much, much better. Here are some examples. That's a columella primary, easy. This is a bigger case with the infiltration I just described between the alar and the lateral cartilage from the internal of the nose vestibule to the skin. So you would have resected all the tip of the nose, and here is the result. He has his own nose, and he is happy with no disease. That's a huge case I've seen in my new institution. I brought him to do the implant in Perugia, and you see that's the superior lip invaded, the skin infiltrated, and the columella and the septum destroyed by the tumor. Here is the implant, a lot of plastic tubes, but look at it. That's the result 1 year later. Alive, with his own nose, with no residual disease. We performed also the neck dissection, 1 node positive, on the right side only 1, without extracapsular spread, no irradiation after the treatment, alive, no disease, just local treatments, brachytherapy and surgery. So that's the clear case to show you why brachytherapy is perfect for midface and vestibule. You can deliver very high doses because you don't have vital structure, and cartilage you want to preserve is pretty much resistant to radiation. So it's a big advantage. And what is a problem for reconstruction? The exposure, the easy to expose and the very anterior lesion, and so you have big reconstructive issues. It's an advantage when you need to make the implant because you can do it also under local anesthesia and have the tumor in your hand and control it very well and cover all the lesion with your catheters. And these are some examples of midface. You see a vestibule, you see a superior lip, you see a cheek and labial rim. These are the oncological results. On the left you see all the nose vestibule series. Some of them were recurrences, but if we look just at the primary cases, we see that we just had 1 death in the T3 case, but all the other cases are still alive and well. So very good oncological results. And brachytherapy since then became our standard for treatment of nose vestibule diseases. Of course, you have always to treat the neck, as indicated. So neck is always the most critical issue in all of the neck cancer, and it is also in the vestibule, so never neglect the neck, and if you have a doubt, just dissect it. And then you may ask me this question: it's so much radiosensitive, why not external beam? The answer is in this data I'm going to publish in the next month. I will be very fast because I'm running out of time. And we had 15 patients with a long follow-up treated by brachytherapy. We had some healthy, normal control. We had some patients treated with external beam. We performed some easy standard tests to evaluate nose function. We started to see, as everybody knows, a lot of crusting in the patients treated with external beam, no crusting in the patient treated with brachytherapy. When we go to the quantitative parameter, external beam patients have markedly and significantly worse olfaction than healthy control, while our brachytherapy patient had not a worse olfaction. But the most striking difference is in mucociliary clearance. We have a high rate of metaplasia in the patient treated with external beam, with the mucociliary clearance clearly compromised, while patients treated by brachytherapy have a normal mucociliary clearance, normal mucous function in their nose. Then you will go to the literature, you will look, say, oh, he's saying it's a new standard, but no complication? and you will find septal perforation and alar perforation. I tell you why. Because it was the radiation oncologist to do it. Then we started to do, in my department, the surgeons. It's all patients implanted by me. And I know some anatomy of the perichondrium and of the cartilage of the tip of the nose. So I started to implant, not following the Paris system, which is the Bible for the radiation oncologist, but following the anatomy, which is the Bible for us. And if you respect the anatomy, if you don't pierce the perichondrium of the septum and of the ala of the nose, you will preserve the feeding for the cartilage, and you will not damage the cartilage itself. We had no septal or alar perforation. We learned to place all the metal guides before placing any of the plastic tubes. You see here, these are the metal guides. It's an easy lesion in the columella. And we learned to enter the skin as far as possible from the tumor to stabilize better the tubes, because it's a key point when you do brachytherapy, and to better control the dose. And you see here at the end, all the, sorry, I go to the end of the movie. Okay, you see here at the end, all the metal guides are placed, and now we pass inside them the plastic tubes. Okay, following this scheme, never violating the perichondrium, not externally nor internally. Final implant, that's the lesion, that's the final implant, and that's the result a few months later. Perfect, no residual disease. In conclusion, we need to change AJCC staging. Nose vestibule is another subsite in the nose and nasal cavity malignancies. So we will have maxillary sinus malignancies, nasal cavity proper and ethmoid, and third, nose vestibule. And we have to adopt the criteria of the Wong staging system. The brachytherapy, in my opinion, and we can discuss about it, it's clearly the new standard for this lesion. It's not acceptable anymore to perform external beam and neither total rhinectomy in CT1 and 2 patients according to Wong. Just when you have bone infiltration, still there are not enough evidence supporting brachytherapy. But if you want to do brachytherapy properly, you need to remember that's a multidisciplinary tool. So you have to exploit the specific skills of the specialists involved. The implants must be done by the surgeon following the criteria I just told you. Never pierce the cartilage, respect the anatomy, enter far away from the tumor, and so on. And of course, the treatment planning must be done by the radiation oncologist, who will be amazed by the fact that it can really raise the dose, even if it's not much homogeneous as the external beam, considering that the cartilage resists to the radiation itself. Again, join us, it will be fun. It's a wonderful place, the best seaside in the world, if not the best faculty, but I think the faculty is good as well. So, thank you very much, and glad to answer to any question.
Thank you, Francesca, for very interesting talk. And I would like to inform you we are already on satellite symposium. It's very interesting symposium. Dilyana allowed us to spend a couple of minutes for questions. Maybe questions from audience. Yeah, please.
Nice presentation. My question is, what's the rate of recurrency after brachytherapy? And is it next step surgery or again brachytherapy?
Okay. Very nice question. To the first question I can answer easily. So if you treat them primarily, because the problem in recurrences is the spread of recurrence, which is unpredictable. So we had, when we treated recurrences by brachytherapy, we had recurrences on the cheek, on the deep tissues. You never know where the residual is. But in primary cases, if you exclude bone invasion, so T3, in T1 and T2, according to Wang, primary cases, we had no local recurrences. We had just one neck recurrence in the follow-up, which we treated by neck dissection and radiotherapy, and she's still alive. So the only failure we had was in T3. in the primary case. Otherwise, it's amazing high local control because you can go very high with the dose without serious toxicities. That's a great advantage of brachytherapy if compared with external beam. So no local recurrence, that's the message in T1, T2. The second question is, again, brachytherapy, I don't know. Because, well, if we stay to the biology and to what we observed, in theory you can give another dose. I'm not pretty sure you can give another effective dose, and I'm not pretty sure, on the biological point of view, a tumor which recurred after brachy in field, so it was already radiating in that area, can be safely treated, can be effectively treated with radiation. I expect that a recurrence will be in a large tumor where we force the indication and it will be an out-of-field recurrence. So in this case, it's rational to do brachytherapy again. Otherwise, if we have a small tumor all covered by brachy, we gave a high dose, it recurs, probably you can give another dose because the toxicity is very low, but it's not rational because it will be radio-resistant. So, but we in the cases of the mid-phase, we never used brachytherapy twice in the present series. We have some ethmoid adenocarcinomas, which were, and some nose melanoma in another group, which were treated twice or even 3 times with brachy, but not in this group. So I don't have data to answer to this.